Well, let me get everything shared. One moment. This always seems to be a little clunky on my side, especially because I can't see that button. No, that still did. Oh, wait.
It looks gorgeous.
Okay, thank you so much. Well, I sure appreciate the introduction. We are all about the show having must go on. So here we are, we're doing this. Today I'm going to talk to you guys about stimulants use in ADHD. If my voice cracks, I do apologize. If I am unclear, please have me clarify whatever you need me to in the chat. I'm happy to do so. I do have a disclosure that I do want to let you know about. I was a part of a COVID research therapy trial last year. It ended in January of 2021, and it was with Eli Lilly and the NIAID. That subject matter is obviously very unrelated to what it is we're going to talk about today. I do have some brand name medication mentions in here, and it's mostly because of the novel dosage forms that are available. And so please note that that does not mean that I feel that one is better than the other. I really do take these in two different batches, and I will give you some specifics on how one may be favored in certain situations over the other based on their pharmacokinetic principles. Excuse me. For learning objectives, we will talk about guideline-based guidance on prescribing ADHD medications, but I want to highlight the preschool age child. That tends to be a little muddy, and so the guidelines really do talk about that specifically. We'll then talk about medication therapy choices based on patient history and medication experience, and then talk about a few of those novel dosage forms that are available. This is part 1 of 2. This is the stimulant section. In a couple weeks, we will go into the non-stimulant options for ADHD. So that's where we'll really get more into the Strattera as well as the clonidine and guanfacine options. There are 3 different guidelines available. The newest one was updated in 2019, and that was the American Academy of Pediatrics. I have made sure that these slides are consistent with what it is that they recommended, and that actually complements what it is that Dr. Deshpande presented last week. And so please note that there are a few other guidelines as well, but for the most part, in general themes, they really do agree well on what it is that they recommend for kiddos. Whenever you're looking at ADHD in the child that's aged 4 to 5, you really want to make sure that you are thinking about what to do with that kid. You don't want to jump right into medications if possible. You want to have them assessed and look into behavioral interventions first. And the AAP, the AACAP, and the NICE guidelines all agree in that realm. They really do want you to go with the behavioral intervention first, including personalized classroom strategies, parental psychoeducation, and behavioral management techniques. With that being said, there are always going to be situations where medications may be prescribed out of order. There was a study that looked at board-certified child and adolescent psychiatrists and how they followed the guidelines for behavioral management as first line before initially initiating pharmacotherapy. Most of the time, whenever those weren't followed, it was because of physical safety or educational concerns with that kid and wanting to make sure that they were able to get that kid to a safer and a safer place where they could get back to school. For the most part, though, there is a clinical decision tree that you can follow. If agreeable to medication, stimulants really are the first line therapy if a medication is going to be selected. You want to talk about the benefits and the risks associated with those and determine that a patient is appropriate for therapy. If that stimulant is ineffective or intolerant, you can change to the stimulant class that hasn't been used yet or augment that therapy if needed. For augmentation, if there's a partial efficacy, you want to think about the alpha-2 adrenergic agonist. And if there's no efficacy after 2 stimulant trials, that's when atomoxetine or Strattera can come into play, or an alpha-2 adrenergic agonist. It is important, though, to think about the additional considerations that come along with prescribing a medication. And that's going to be the desired length of coverage time for symptoms. So whenever you think about it, in an ideal place, you would start with an immediate release medication. But does that immediate release medication in its duration of therapy last long enough to cover the time of day when symptoms are occurring? When is the homework going to be done? At what time is the teenager driving a car? When is a kiddo's bedtime? Different things like that are all going to really play into how long you want that medication to act from the time that it is swallowed to the time that that onset of action dissipates below that level of minimum effectiveness. Can the kiddo also swallow pills or capsules? And if not, maybe consider other dosage forms in that situation. Do they have any other concomitant disease states that may lead you down the path of prescribing something that may be more for tics as well as the ADHD symptoms? What is the adverse effect profile of that medication? Is it possible that this certain stimulant carries more of a risk of psychosis or an increased risk of behavioral concerns or different things like that? Those might all play in. And a lot of that may come from your personal experience as a prescriber that then leads you down the path of kind of being in tune to some of those adverse effects. Also, concerns about abuse or diversion potential is something that always comes up in a prescriber's mind and possibly a parent's mind whenever it comes to this. But it is important to note that children with ADHD are more likely to have concurrent substance use disorder. And if you treat ADHD, that actually reduces that risk of substance use disorder. And so there is advantages to getting them on therapy at a younger age. Those kids that are started at a younger age to treat their ADHD appropriately with medications are less likely to misuse and abuse substances versus those in whom treatment is delayed, which is a really good thing to encourage your parents and those that may have that as one of their issues with starting medication therapy. And lastly, and potentially most importantly, the expense of medications has to be taken into account. So often you hear about these new dosage forms that come out that appear to be superior and look really great on the outside, and everything is all well and good. And oh, it's just a new brand name of an old generic that we've had around for a really long time. But there's something about that dosage form that makes it novel. Well, the drug companies aren't dumb, and they want to make sure that you know what's advantageous about their product specifically because they're trying to sell it, right? So the expense of that medication may not be worth the small added benefit of what you gain from that new dosage form. So you always want to go back to your fail safes. And with that in mind, I have included a table in this presentation that walks you through, as of today, the OHCA coverage of the stimulants for ADHD treatment. And so I think that can kind of guide you. Just know that that table can most definitely change over time. Let's talk about the medications now. There are these two groups of stimulants that typically are on an even playing field. There are some things that are going to have methylphenidate take a nod above amphetamine derivatives, and we'll walk through those. Let's start with methylphenidate. It is a mild CNS stimulant that blocks the reuptake of norepinephrine and dopamine into the presynaptic neurons. And that mechanism of action might sound familiar to you. We do have an antidepressant that actually works through that same mechanism, and it's bupropion. It might be why you see some adults who have ADHD prescribed bupropion off-label. This medication, methylphenidate specifically, appears to stimulate the cerebral cortex and the subcortical structures, similar to the way an amphetamine substance would. There are two gold standard studies that we think about when it comes to methylphenidate. The first is the MTA study, and Dr. Deshpande did a really great job of introducing these. The MTA, or the multimodal treatment study of children with ADHD, showed both groups who received algorithmic medication management having a superior outcome to those with community management or behavioral therapy alone. And again, remember her talking to you about those 4 different treatment groups where you have the medication only, the community therapy, the medication plus therapy, and then the therapy by itself. Lots of the kids who were in the meds plus therapy group showed that best result. And so really in this study of children, we really do want to emphasize that that can be best done in combination with medications and therapy. Now you're looking at younger kids in the PAT study. This is the preschool ADHD treatment study, and it was done with methylphenidate immediate release in our kids aged 3 to 5 years old. This was funded by the National Institute of Mental Health, and it ultimately showed a significant reduction in ADHD symptoms with parent and teacher rating scales. But the effect sizes were smaller with these kiddos than it was the older kids. And so with the older kids, we saw a better result with methylphenidate than we did with the preschool age children. Based on these two studies, the adverse effects that we saw with them include anorexia, difficulty falling asleep. So no surprise there when it comes to what a stimulant is going to do. It's really going to just activate and excite the brain and make it really difficult to kind of settle down. In the preschool age children, though, we did see an increase in irritability, emotional outburst, crabbiness, repetitive behaviors and thoughts, and as well as a reduction in growth rate. It is important to note, though, in that PAT study, there wasn't a lot that was looked at beyond the point of them turning into older children. And as Dr. Deshpande mentioned last week, that growth can rebound in older children after the discontinuation of the stimulant. It is important to note that there were no significant increases in blood pressure or heart rate in the PATS study or the PAT study. And that reduction in height was about 1/2 inch per year. And the reduction in weight was about 1.3 kilos per year. When you're looking at these medications, you also want to know about how often they discontinue them based on these adverse effects. And the preschool age children discontinued far more often than the multimodal study with adolescents. Despite all these positive outcomes results of the PATS study, methylphenidate is still the only FDA-approved agent for treatment in ADHD kids, but that's only from 6 years old and up. And you can see this in my drug reference here. They still can be used in our younger preschool age children. Just know that it continues to be off-label. When you're looking at dosing methylphenidate for an immediate release picture, you want to dose very low doses twice daily. This is typically going to be given with breakfast and lunch to avoid GI and sleep disturbances. With that being said, this isn't a very convenient dosing regimen. And so this is why some of those other dosage forms that may have a more extended release picture or profile are going to come into play and may be favored above that immediate release picture. So whenever you are thinking about that, just know that there are some ways that you can convert to extended release by totaling that daily dose of immediate release. From a safety perspective, again, as we saw with the kiddo studies, we saw a loss of appetite, insomnia is possible, abdominal pain is one of the other things that can happen, as well as nervousness. This may exacerbate the pre-existing hypertension or tics that may exist in your child. And there are labeling warnings of potential sudden cardiac death with the starting of methylphenidate. With that being said, in the American Academy of Pediatric guidelines, they discuss that although these medications are not recommended in patients with known structural or heart defects, there's no established evidence on that causative relationship. And so it's possible this is just a correlation that was seen in the research. The frequency of sudden cardiac death was actually the same as it is in the general population. And just to be safe, though, the American Academy of Pediatrics do recommend a very targeted cardiac history and physical exam before prescribing these medicines. All right, this is the most talking I've done in a long time. Okay, methylphenidate products that exist. I have 2 slides for you, and these walk you through the generic, and then in parentheses, I do have the brand name. The little asterisk next to the name signifies that there is a generic available of these. And then you have the delivery system in that second column. I've ordered these in their duration of activity by hours. And so at the top of these screens, you're going to see the shortest duration of activity. And on the bottom of the second screen, the second chart coming up, you'll see the longest duration of action. And so all of those might help you decide which one to prescribe and when. The other thing is you might be able to see how they compare to their counterpart and and what it is that makes them different that you may want to try to fight for when it comes to tiered based insurance coverage approaches. So on this screen, you see the basics. You see the immediate release Ritalin and methylin, as well as the Focalin. Each of these are in tablet forms, but you also have a chewable or an oral solution available that are going to be roughly around 3 to 5 hours in duration. And then you pick it up a little bit with the sustained release and the extended release, where you're going to see a little bit longer duration of activity. There is a newer dosage form that's called the QuillaChew, and this is a chewable tablet that has a little bit more of a like a beaded texture that then allows those little beads to dissolve slowly over time, giving it a little bit longer of a duration of activity in 8 hours. Dexmethylphenidate is Focalin XR. You're going to hear that one a lot. That one's a pretty common one that's prescribed. And it has a 50-50 ratio of immediate release and extended release beaded medication beads, wow, that are they're encapsulated and then slowly release over time over about 8 to 12 hours. On the next one, so this is our next part of the table, you have Daytrana, which is a patch. This is going to last around 11 to 12 hours. You put this on and you can leave it on up to 16 hours, but know that that duration of activity is going to extend a few hours beyond the point of removing that patch. And so you want to think ahead to when that patch is removed, because you're still going to have the effects of it for a few hours beyond its removal. You also have Metadate ER and Relexi. These are 12-hour tablets. Concerta is a pretty common medication, and I do have a specific slide on this one because it has this really interesting drug release mechanism, and it lasts about 12 hours in the system. Contempla XR is a chewable ODT, an oral dissolvable tablet. So you just put it on your tongue and it dissolves, and it lasts about 12 hours, which is also pretty cool. Quillavant XR is also an interesting form because it comes in a suspension. And then lastly, you have methylphenidate extended release and a few different brand names that is a capsule with multi-layered beads inside. The majority on this slide are 12 hours in duration, which is pretty cool. Okay, the first novel dosage form in the methylphenidate section is Concerta, and it is in an an osmotic release oral system that has 3 layers. And I have this image of the capsule for you here, where you see that yellow that's surrounding the outside is an immediate release overcoat that has a portion of the medication in it. And this one is about 1/5 of the medication. That's going to dissolve and be immediately available to your kiddo. After about 1 hour, you can see that green compartment down low. That push compartment starts to expand, which then pushes out the drug compartment 1 from that little orifice or the exit port. And then eventually that drug compartment in part 2 is released. And so you can see how over time it just slowly releases this medication in the immediate release, as well as in the compartments 1 and 2, which are more of an extended release picture. When you are looking at how to dose these, it comes in a few different milligram strengths, and you want to take into account the initial dose of the methylphenidate in order to determine how much to prescribe for your patient right out of the gate. The next novel dosage form that exists is the transdermal patch, which I've already mentioned. This is Daytrana, and you can see that it is applied daily for up to 9 hours to hopefully get you somewhere around 11 to 12 hours of effectiveness, because those effects are seen about 1 to 2 hours after about 3 to 4 hours after the removal. You want to place it on the hip and rotate the site placement, and initiate all patients on the same milligram patch, regardless of what they've been on in the past. So that is important to note, and that does differ from previous dosage forms. This medication has been linked to a higher rate of insomnia, anorexia, and tics. And so it is important to be watching for those adverse effects, because they may be ones that become intolerable to your patient, or you can just adjust at what time you put the patch on and what time you take the patch off. It doesn't have to stay on for the full 9 hours. You can remove it sooner if needed. I think I would be remiss if I didn't mention to you, though, whenever you do take these patches off, it's very important that you dispose of them properly. And the best way to do that would be to take the patch and fold it in half, and then put it in a substance that's not going to be easily accessible to kids or pets. When you're thinking about a few different pharmacokinetic considerations, know that kids may metabolize medications quicker than adults. And so when you're looking at these durations of activity, you might see that one kid doesn't get the full duration of activity that's quoted in that package insert. And that may be because their system, their liver is just working in higher demand and doing a better job than us adults. And so because of that, you may either need to think about what dosage form you're providing or consider an immediate release dose at some point to supplement that therapy. You also want to assess the effect in the patient instead of the expected number of duration of therapy, which is kind of what I just mentioned. And then another point to think about would be how some studies showed the concentration in kids were 2 times higher than adults or 2 times lower. And so really just I can't emphasize enough the unpredictability that can come about with some of these medications. And so you do want to be conservative in starting, but also very in tune to how it is working for your patient. We're going to switch gears now and we're going to talk about the amphetamine level of products. The mechanism of action is going to be very similar. These are non-catecholamine sympathomimetic amines that promote the release of dopamine and norepinephrine. So very similar to before when we were inhibiting the reuptake of dopamine and norepinephrine in the presynaptic neuron. Now we are promoting the release of that from storage in the presynaptic nerve terminals. We can also block some of that reuptake as well by competitive inhibition. I was able to get all of the products on one slide here. And so hopefully this is of use to you as well. But whenever you look down, I've organized these in the same way in duration of activity. So you have these shorter duration of action, including Adderall and Evakeo, excuse me if I pronounce that incorrectly, as well as Procentra and Zenzetti. These are your mixed amphetamine salts or dextroamphetamine products. Dextroamphetamine also has an extended release that is a beaded capsule in a 50-50 ratio called dexedrine spansules. That lasts a little bit longer, so more 6 to 8 hours. You have a mixed amphetamine salts, which is probably the most common on this table, and that's Adderall XR. This is 50-50 as well, IR to ER. And it lasts anywhere from 10 to 12 hours. And so it does provide a little bit more coverage throughout the day that may cover not only your school time, but also a little bit of home and homework time as well. You also have oral suspensions, you have oral disintegrating tablets, and then we will talk specifically about Vyvanse because that one is a pretty common one with a novel dosage form as well. This is lisdexamphetamine, and it lasts anywhere from 10 to 12 hours usually. There's a pretty new one as well that takes it all the way up to 16 hours of duration. And this one is called Mideus. So I'm not exactly sure what it brings to the table other than that increase in duration of activity. But if you think about that, 16 hours is a really long time to be like on it all the time. And so just know that that may be a very specific patient that you're looking for there, one that doesn't require as much sleep as, let's say, a kid might. When you're dosing amphetamines, it should be pretty low and pretty slow in titration. Adolescence is going to match your 6 years old and up, but your max daily dose is about double that with the extended release version. Excuse me. Oh my gosh, sorry about that. Okay, mixed amphetamine salts. These are the extended release version. This is Adderall XR. So again, probably the most common one that you have here. This is going to mimic your twice daily dosing of the immediate release. Again, remember, we've got those little beads in there that are going to provide that immediate release and extended release coverage. This does have a longer half-life than methylphenidate. And so it then is going to hopefully, in theory, last a little bit longer because of that. And the nice thing about this is a kid doesn't necessarily have to be able to swallow a capsule because it's fairly large in order to get this in their system. They can sprinkle this on cold or room temperature soft food. So think yogurt, think applesauce, pudding, something like that. A kiddo can still be able to take the advantage of Adderall XR, even though they can't maybe potentially swallow a capsule yet. Vyvanse is the one that I think is a pretty interesting dosage form. And for our med students that are on your rotations that are on on the line today. This one might sound familiar. So this is one of the few that is a prodrug, meaning you take it in an inactive form, and then it has to be cleaved by hydrolytic activity of red blood cells before it turns into its active form of dextroamphetamine. So lisdexamphetamine is ingested, and then this there's a lysine molecule that's attached to this medication. It has to be cleaved off. And the only way to do that is through the red blood cells. So it kind of provides its own controlled release mechanism in that sense. This one is a pretty interesting one in that it doesn't have clinical superiority to other formulations, but if there is a concern for abuse, this one does kind of lower that potential. This is going to be good for kids with adherence issues, but it does have the potential to cause a higher incidence of insomnia. And anecdotally, this one has been linked to a little bit more aggression than others. And so if that's the case, then you might want to think about switching them from Vyvanse to something else. The other thing that is curious about this one is that it can also be used for binge eating disorder, which is maybe one of the reasons that you'll see this one prescribed in that population. If you find that your kid that you're prescribing for is requiring higher and higher doses of Vyvanse, you might, and this probably goes without saying for all of our medications that we have here, it might be because of some missed comorbidities there. And so you might want to just reevaluate the diagnosis in general. If you do get to that place where you're escalating that dose and it's up and up and up and up, and you're still not seeing the benefit, because this one tends to have a pretty decent response for those that do take it. So another novel dosage form is the Adzentis XR. This is an oral disintegrating tablet. It extends out its duration of action because you've got a 50-50 IR and ER release capacity here. The other unusual thing, you don't usually see a chewable medication with this extended duration of action. And so that is something that's kind of interesting and cool about it. You can take it with or without food, but it does have a travel case that you want to make sure that you counsel your patients on making sure that they use that to take it so it doesn't disintegrate. All right, a few pharmacokinetic considerations with these. Children may eliminate amphetamine faster than adults. There are some that had higher systemic exposure than adults as well. Lisdexamphetamine, the clearance was decreased with impaired renal function. And so you do want to make sure that the serum creatinine is appropriate and that clearance is okay before starting this one. And then amphetamine sulfate and mixed amphetamine salts, as body weight increases, that systemic exposure and maximum concentration may decrease. So those are all kind of an interesting things to consider. Let's jump right into general pearls with stimulants. I promised you a slide on the Oklahoma Healthcare Authority tiers. This was based into 2021. I will keep my eye on whether this is updated for 2022 or if there are any changes. But for the most part, you can see here, tier 1, tier 2, and tier 3. These are what OHCA will do their prices based off of. You will see over on the far side, however, that a lot of our amphetamine products or dextroamphetamine products have special prior authorizations required, and a few of our methylphenidate products as well, including the Contempla, as well as the methylphenidate chew tablets. So the other thing to note is Focalin XR, the brand name, is what's preferred tier 1 compared to the generic Focalin XR, which is tier 2. So some unusual changes there, but just confidence in that brand name over the generic there. Excuse me. Adverse effects that you are going to hear are similar to what we've already talked about. So these, as Dr. Deshpande mentioned last week, they're like a cup of coffee. And so anything that a coffee would do to you, think that one of these stimulants may do as well. So it might cause your blood pressure to go up, tachycardia, impaired sleep, appetite suppression. But the warnings and precautions here include growth suppression. And so you want to make sure you're monitoring height and weight. Also, if your child has a history of cardiac disease or a family history of sudden cardiac death, palpitations, syncope, you do want to flesh that out a little bit more. The rare adverse effects here include the fact that tics may be uncovered with stimulants, and that mood and affect changes may be dose related or due to concomitant diagnoses. And remember that Adderall had a slightly higher risk of psychosis, as did Vyvanse shows some behavioral and aggression changes. You want to assess the response in 1 to 2 days after initiation. That optimal response isn't going to be achieved until about 1 to 2 weeks after start. If they don't have a response, you want to reevaluate your diagnosis and consider a trial of a non-stimulant such as atomoxetine, clonidine, or guanfacine. And that partial response, again, remember, go back to augmenting with an alpha-2 agent. Time to response is going to take longer with our non-stimulant class, however. I did want to include a slide on drug holidays. So it was mentioned last week how if you have a kid who has growth suppression, a drug holiday may be something you want to consider. And that's going to be during the times that they don't have a lot of schoolwork going on. So maybe that's spring break, Christmas break, summer break, things like that. But you still want to make sure that you are including activities that challenge them so you can assess how they're doing during those times of drug holidays. For the record, however, these are not typically recommended due to the pervasive and chronic nature of ADHD. This really does need to be a case-by-case decision that includes the parents and the providers, as well as potentially the teachers, depending on how much into the school year you are. There are a few other uses for stimulants. I've mentioned Vyvanse with binge eating disorder. The majority of these others on this list are used for narcolepsy, but methylphenidate IR can also be used for depression in our terminally ill patients who are requiring palliative care. And so that is an interesting one to add here. The other thing is that this can be used for cancer-related fatigue. So these may be prescribed for other reasons and just things to kind of keep your tabs on. In summary, I have a few take-home points for you. I can't emphasize enough behavioral therapy for our preschool and younger age children. Stimulants should always be paired with this in order to see the best benefit based on those studies we talked about before. Methylphenidate is often tried first based on the MTA. There may be certain things that lead you down the path of amphetamines first, but those should probably be documented fairly well. And then always know that if that methylphenidate or that amphetamine is ineffective, flip-flop to the other stimulant to see if that works before moving over to the non-stimulant class. Utilize those novel dosage forms to see the max benefit with minimum adverse effects as well. Got a ton of references as always. So my guidelines are listed here for you. I do have a few miscellaneous references that are more pharmacy focused. And then I have the PATS and the MTA studies here for you. With that, I would love to pause. I'm going to take a drink, and I would love to answer any questions that you may have.
Thank you, Kelly. I think I see a question from Crystal Fessler. I've seen some information regarding food/caffeine usage impacting the efficacy of medications. Do you have any resources regarding this?
That's a really, really good question and an interesting one. I don't have any information for you other than just from a more anecdotal perspective. It kind of makes sense to me that caffeine would ramp everything up and maybe cause a little bit more adverse effects that the stimulant may be blamed for. And so that's something that you may take into account there. As far as efficacy goes, though, I'm unsure. Dr. Deshpande, do you know anything about that?
So there, in my clinical experience, there is some evidence that food coloring and red dyes can cause. And I was just looking at a meta-analysis that I will actually put in the chat box on the food coloring. So essentially, it's not for every child, but some children might be more sensitive, and they do talk about about it in the paper. So and again, we don't have any clear things, but when I work with parents, I have parents talking about sugar, food coloring, red dyes, not so much caffeine. So that's kind of what my clinical experience has been. I see another question or a comment. I have heard some information about using magnesium citrate to support medications. Is this accurate?
I know that there isn't anything in the American Academy of Pediatric guidelines associated with this. As far as if it helps with mechanism of action, that doesn't really, that I can't put it together what it may assist with. I am happy to take a look at any references that you may have seen that kind of lead you down that pathway. However, yeah, I'm unsure. I don't think I've seen that. Sorry, I don't have a great answer for you though.
I actually have a little bit of experience with complementary and integrative medicine
Great.
committee for ACAP, and we have actually looked at several of these integrative, complementary chemicals, substances, and I haven't really come across magnesium citrate for ADHD. There is some evidence that magnesium citrate, magnesium glycinate, magnesium threobromate can help with sleep. So there is some evidence with that, but not ADHD. And I mean, if sleep improves, ADHD might, but I have not seen any direct evidence for magnesium and ADHD. Again, a great question, Kelly. Amazing presentation in spite of COVID. Thank you so much for being